Alzheimer and vascular pathology in Down syndrome. So I hope by the end of the presentation, I will have convinced you that the Down syndrome population is a very important population in which we should study the Alzheimer's disease, and also a very interesting study population to study the interplay with the vascular disease. So I will first start by giving you a few numbers about the prevalence of the epidemiology of Down syndrome. So the incidence is around 1% for every 700 live birth, and we consider that the current prevalence worldwide is estimated around 6 million persons, including more than 32,000 just in Spain. So the number of people living with Down syndrome has increased drastically over the last years. You can see here the data for the Southern Europe, where we can see that in 1950, the data from 1950 to 2015. And if you look at the evolution of this curve, you can see that from 1950 to 1990, the population with Down syndrome has more than tripled. So what explains this very much increase in the population is that the people with Down syndrome progressively have longer life expectancy. They have longer life. And this is because we have improved a lot in the way we are treating them. And especially, we are now able to treat congenital heart defects. So this has increased a lot the life expectancy. And this can be visualized on this study that we conducted some years ago using mortality data from the USA, where you can see the evolution of age at death from 1970 to 2020. And I would like you to focus on this blue line, which represents the median age at death in the Down syndrome population. Okay, we can see that in 1950, the median age at death was around 20 years, while it is now reaching more than around 60 years. So this is a major change in the life expectancy of these people. There's another very interesting observation that we can do on this graph, is that the life expectancy is somehow capped around age 60. You can see that this percentile for age at death of the 90th percentile of the population, the 75, since the 1990, they kind of plateau, and the people with Down syndrome, despite the advance in medicine, are not living longer. And this represents a major gap in life expectancy as compared to the general population, because we are speaking of around 25 years. And the reason for this difference with the general population is Alzheimer's disease. So the people with Down syndrome are genetically determined to develop Alzheimer's disease. And the reason for this is that they carry a triplication of the chromosome 21, which contains several genes that are associated with increased risk of dementia. But one that we think is playing one of the most critical roles is the APP gene, which codes for the amyloid precursor protein, and which is going to lead to an overproduction of the amyloid protein, which will eventually result in amyloid plaques. So we consider in the field that the APP gene is necessary and also sufficient to cause early onset Alzheimer's disease in individuals with Down syndrome. So the consequence of this triplication is that people with Down syndrome will develop at a very early age Alzheimer's disease pathology. So you can see on this graph from a review from our group, from my colleague Juan Fortea, that the diffuse plaques start to be seen at the teenager year, and virtually all individuals have diffuse plaque at the age of 30. They eventually develop neuritic plaque and neurofibrillary tangles, and we consider that virtually all individuals have AD neuropathology in the brain, both amyloid and tau tangles, at the age of 40 years. So a consequence of this pathology is obviously that the people develop cognitive symptoms. This is a graph that is showing the prevalence of MCI, programmatic, and Alzheimer's disease dementia in the Down syndrome population with data from our cohort. And we are seeing that starting from the age of 40 years, people with Down syndrome start to develop prodromal AD or dementia. And this increased drastically with the years, with at the age of 60 years, most individuals already showing dementia. In a meta-analysis, we actually observed that of the different studies across the world, we actually observed that the average age at symptoms onset is 53.8 years. And in this study, it was interesting because we also look at what was happening in the field of autosomal dominant Alzheimer's disease. And what we observed is that the variability in the age at symptom onset in Down syndrome is actually very similar to the one that you will see in other genetic form of the disease. And we published a follow-up paper on this, including ApoE4 carriers, and we also show a similar variability in the age of symptoms onset. Additionally, our group and others have demonstrated that the pattern of Alzheimer's disease biomarker change in Down syndrome is also very similar to the one you will see in autosomal dominant AD, with first the amyloid biomarkers that are showing some change, followed by the tau biomarkers, and finally the neurodegeneration. So if I summarize a bit this result, it is demonstrating that Alzheimer's disease is almost inexorable in this population. So we know that virtually all these individuals will eventually develop Alzheimer's disease, and this represents an opportunity for us to study the earliest stage. We also have observed that Alzheimer's disease in this population can be predicted, at least as well as in what we do in autosomal dominant AD. And we can therefore use index like estimated years of symptom onset as continuous metrics to study the disease pathology. And all this is indicating us that is very critical to understanding this population or Alzheimer's disease develop, and also to try to understand which factors can influence the disease trajectory. So our group has been very involved in this direction. We have conducted several studies. For instance, we look at how the ApoE4 allele could influence the natural history of Alzheimer's disease in Down syndrome. And it was very interesting because we observed that the carriers, the ApoE4 carriers, actually developed the disease 2 years earlier than the non-carriers. And we could observe some effect on the amyloid biomarkers and also on the topography of the neurodegeneration. So this indicates that even in the context of a genetically determined form of Alzheimer's disease, the ApoE4 allele can influence the disease trajectory. We have also performed other studies. For instance, I show this one about the effect of sex, where we try to see if the evolution of the disease was different in male and female, and we couldn't evidence much of an effect. We did see a certain signal when we look at the interaction with the ApoE4 allele. I won't enter too much into the detail at the moment on this, but we can come back on it later on if you're interested. What instead I would like to discuss to you today is one of my main research lines, which rely on the neuroimaging and try to characterize the pattern of structural and functional change in the brain associated with Alzheimer's disease in people with Down syndrome, and also the study of the vascular lesion and how they can interact with Alzheimer's disease pathology. So for our study that I will present you, I'm using data from the DABNI cohort. DABNI stands for the Down Alzheimer Barcelona Neuroimaging Initiative, and it is a cohort that started in 2012 to study Alzheimer's disease biomarkers in adults with Down syndrome. So all participants are recruited from a population health plan that is occurring in Catalonia and that is performed at the Alzheimer Down unit. All the individuals are invited to undergo annual medical review, including neurological and neuropsychological examination, blood test, and also an EEG. And we invite them to participate, to accept, whether they accept to participate into a research program. We also propose them to undergo some biomarker examination. So in this context, we propose, for instance, lumbar puncture and plasma extraction, genetic testing, different neuroimaging examination using MRI or PET, sleep study, and also brain donation. So at the moment, our cohort includes more than 1,100 individuals, all older than 18 years. And our clinical team has done more than 10,000 clinical visits. So this is massive. This is one of the largest cohort worldwide with Down syndrome. If we consider only the neuroimaging data, we have more than 300 MRI at baseline. We have also some follow-up data. And regarding the PET, we have more than 160 FDG PET to measure the metabolism, more than 130 amyloid PET, and we are also starting to acquire more and more tau PET. So most of these participants do have CSF or plasma examination. And thanks to the exhaustive clinical evaluation, we are able, with a consensus diagnosis, to establish whether people are asymptomatic to Alzheimer's disease, whether they present early sign of cognitive decline, like the equivalence of MCI, which we classify as prodromal AD, whether they present both cognitive and functional decline and can qualify for Alzheimer's disease dementia. And we have finally a last group of persons that we have difficulty to classify because they usually present a certain degree of cognitive decline, but that cannot be directly associated with Alzheimer's disease. But you can see it's a very minority in our diagnostic scheme. For group comparison, we are using data from the SPIN cohort from the Central Memory Unit. We have data from various different degenerative disease, including symptomatic sporadic Alzheimer's disease. And we also have the data from cognitively unimpaired individuals. So I will move directly to the result and present first some data related to the structural alteration in Down syndrome, so that you have a sense of what has been done in the context of Down syndrome. It remains a lot to be actually studied in this condition. And for instance, there is almost no study, to not say none, that explore the pattern of atrophy at the MCI stage of the disease. So this is what we did. So here I'm showing the pattern of decreased gray matter volume in prodromal Down syndrome, so Down syndrome at the prodromal stage of Alzheimer's disease, versus asymptomatic, so that did not present any cognitive decline. You can see that the pattern of atrophy mainly include the temporoparietal region, and this pattern increase and encompass all the cortex when we reach the dementia stage. If we compare the patient at the prodromal and those at the dementia stage, we observe difference in gray matter volume that predominates in the temporal lobe, especially in the medial temporal lobe and the lateral temporal structure. So overall, this is a pattern that is quite similar to the one that you could observe in the general population and in sporadic Alzheimer's disease. So we wanted to go one step further and try to understand the evolution, the sequence of the atrophy without taking into account the clinical group. So what we assess here is the frequency of brain atrophy for different brain regions. So each line represents one region of the Hammer Atlas, and I'm plotting the percentage of cases that present significant atrophy as compared to the euploid population. On the x-axis, you have different thresholds to define the degree of atrophy, but we don't mind this very much because we can apply a very standard threshold. And when we apply this threshold, we observe that the region that most significantly present atrophy, most frequently present atrophy in the Down syndrome population, is the hippocampus. It is followed by the amygdala, the anterior cingulate, the superotemporal gyrus, and a group of temporoparietal structures, including structures that are very well known in the field of Alzheimer's disease, like the angular gyrus or the posterior cingulate. We also look at the frequency of this atrophy in the different clinical groups, and we observe very similar pattern. You can see that in the people with Down syndrome and Alzheimer's disease dementia, the hippocampal volume, the hippocampus was atrophied in more than 80% of the individuals. We can also observe very clearly on this graph a sequential involvement of the brain structure with some regions that present very little atrophy across most cases, and we saw the region showing a gradual, more frequently atrophy. Similarly, in the group at the prodromal stage of Alzheimer's disease, we kind of retrieve this progressive involvement of the brain structure, even though it is less pronounced, as you will imagine, because they are at an earlier stage of the disease. And when we look at the asymptomatic cases, we observe very little atrophy compared to the opioid group, just the hippocampus that present one of the most. And we found also an interesting result regarding the anterior cingulate, which presents some degree of decreased volume as compared to the opioid population. And we think that this may reflect some neurodevelopmental specificity of the Down syndrome population. So our result kind of point toward the specific vulnerability of the medial temporal lobe in Down syndrome. So I have put this image to illustrate this. On the top row, you have an individual with Down syndrome, 32 years, that is asymptomatic to Alzheimer's disease. The second row is showing the MRI of an individual of 50 years that is at the prodromal stage of Alzheimer's disease. And on the last row, you have an individual of 57 years with Alzheimer's disease dementia. So if you look at the hippocampal structure, which is here, you can clearly observe, you don't need to be a neuroradiologist to clearly observe the progressive atrophy of this structure. It is shrinking. It is quite obvious at the eye. So we wanted to quantify this using advanced neuroimaging techniques. So we used the ASH software that has been proposed by the UPenn group in the US to segment the different medial temporal lobe structures. So this allows us to segment the anterior and posterior hippocampus, the entorhinal cortex just here, the perirenal cortex here that is composed of the Brodmann 36 and Brodmann 35, and finally the parahippocampal gyrus. So for the hippocampus, we used the volume, and for the other structure, we were able to extract the cortical thickness using a new reconstruction proposed by the UPenn. So here are the results when we compare the different groups. You have in gray the haploid controls, so the general population. In blue, the the asymptomatic Down syndrome. In red, the patient with Down syndrome at the prodromal stage, and in green at the dementia stage. So if we go step by step to decode this graph, if we look first at the comparison between the controls and the asymptomatic Down syndrome, we observed that the hippocampal volume was decreased in both its anterior and its posterior portion. Interestingly, we also observed that the cortical thickness of several structures, including the entorhinal cortex, the parahippocampal gyrus, was actually increased in this population as compared to the general population. When we look at the effect of Alzheimer's disease within the Down syndrome group, we observed that the patient at the dementia stage systematically show decreased volume and decreased thickness as compared to the two other groups. And when we focus more on the prodromal stage, we observe only significant difference as compared to the people with no symptom in the hippocampal region. So another way to visualize this result is to project the volume and the thickness against estimated years of symptom onset. So to compute these estimated years of symptom onset, we actually use age, and we subtract from the average age at the population level of symptom onset the age of the patient. So there is one interesting observation on this graph. The first one is that most of brain region present first a plateau or a slight increase before showing quite a massive decrease in their integrity. To better quantify this, we actually fit inflection point for all these brain regions. And what we were able to observe is that the entorhinal cortex is the brain region that showed the earliest drop in integrity in cortical thickness around 15 years before symptom onset. It is then followed by the posterior hippocampus and Brodmann area 35, around 13 years before symptom onset, and then by the anterior hippocampus, and then the following structure, around 10 years before symptom onset. Overall, this is a pattern for those that are not familiar with the progression of tau deposition in the brain and also of the atrophy that you will find in sporadic Alzheimer's disease. Is a pattern of result that is quite consistent with the Bragg staging and also what we can observe with MRI imaging, where often the entorhinal cortex is one of the first structure to present some structural change using MRI. Finally, we were also curious to know if our MRI metrics can help us to predict the presence of clinical symptoms in the Down syndrome population. This may be a bit a silly question, or some certain person don't understand why you will use a biomarker to predict symptoms. We don't see it as like a major, obviously the clinical evaluation remains the gold standard to ensure the symptoms, but sometimes you may have some doubt, especially in the case of Down syndrome, where the intellectual disability may blur the limit between the normal and the pathology. So the support of some biomarker can be useful in this context. So we put all our imaging metrics in one model. We also add the demographic and the certain clinical variable, as well as the CSF biomarker. And what we observe is that the best model to predict the presence of symptoms involve the posterior hippocampal volume, the age, CSF P181, and the cortical thickness of the parahippocampal gyrus. Actually, if you look at the ROC curve, they have very good, this model, which is the first one here, has a very good performance with an area under the curve of 96. It outperformed the biomarker, the CSF biomarker by themselves. But you can also see that the imaging biomarker alone is performing quite good to differentiate this group with an area under the curve of 86. So if I summarize briefly this first result, we observe in the non-syndrome population a pattern of gray matter atrophy that resembles very much to the pattern observed in the sporadic AD in the general population. I have shown you here our result and below results that are from the literature in sporadic Alzheimer's disease and that represent the exact same contrast. And you can appreciate the similarities between the profile. We also demonstrated that the pattern of volume loss follow a stereotypical pattern that initially include the temporoparietal region and then spread to the other brain region over the course of the disease. And we observed the specific vulnerability of the medial temporal lobe, as you would expect, and notably of the entorhinal cortex that seems to present some early change around 15 years before symptom onset. And this is very much in line with what has been reported with tau PET, in a different group with a different cohort, where they observe significant change in tau PET 15 years before symptom onset, so at the same time in the Down syndrome population. So as we think that the tau pathology is the best substrate of the neurodegeneration, it makes quite a lot of sense. Finally, our result, I did not spend much time on this, but our result demonstrate nonlinear change, which probably combine some developmental specificity and also some more change related to Alzheimer's disease, but other process like, for instance, something that has been suggested in our lab, that there is an increased sickness that may be related to inflammation at the early stage of the disease. So beyond structural alteration, we have been also interested at looking at the functional alteration in Down syndrome. We have notably looked at the metabolism in this population using FDG PET. I'm showing here the pattern of hypometabolism in the prodromal stage and the dementia stage. And you can observe that the hypometabolism is mainly found in the posterior cingulate at the prodromal stage, and it encompasses most parietal and temporal structure at the dementia stage. When we compare both the prodromal and the dementia stage, it is mainly the parietal and temporal structure that stand out as a region to discriminate the two groups. So here again, we have a pattern that is quite mirroring the one that you will find in the general population. Maybe something that differentiates the profile in the general population is that we found a bit more of hypometabolism in the basal ganglia and the thalamus, which is not something that you systematically find in the general population. But overall, a profile that is quite similar, though. We also performed the same group comparison against the haploid population. So you have the same result here with the group of asymptomatic, the group of prodromal, and the group of dementia. So these two results are very similar to the one that we have just seen. They are just more significant. But I would like to bring your attention on the first graph, where we are comparing the controls, the haploid controls, to the asymptomatic Down syndrome. And you can already see that with the FDG PET, we are capturing a very extended pattern of hypometabolism. So the metabolism seems to be quite decreased, which may be a specificity of the trisomy 21. But if you look at the topography of the hypometabolism, you can see that it looks like also quite connected to the one that you will see at the prodromal stage. Actually, if we look at how the age is impacting the metabolism in the Down syndrome population in red here, or in the control population, we observe that in this structure, there is a very big drop in the parietal structure. There is a very big drop in the metabolism that starts at an early age, as early as 35 years. In this research article on the metabolism and the FDG PET, we were also curious to know what will be the best pathological correlate of this hypometabolism. So we performed some voxel-wise correlation with the CSF A-beta 4240, the PTO 181, and also the NFL, all measuring the CSF. And we observe very widespread and strong correlation, as you can see here. What was interesting is that when we put the three different biomarkers into the same model, the only one that remained really significantly associated with the pattern of hypometabolism was the NFL, including in the parietal, medial parietal, and lateral parietal region, and also the medial temporal. So this makes a lot of sense because the NFL is a marker of neurodegeneration, as the FDG PET, and it reflects axonal damage, which may be directly linked to the metabolism. So now we are pursuing this line of research regarding the FDG PET, and we are having some ongoing studies trying to see whether the FDG PET is a more sensitive modality to detect change associated with the symptoms in Down syndrome as compared to the structural MRI. These are still quite preliminary results, but the first data we have is that both modalities perform equally good when we try to distinguish patients with symptoms from those without symptoms. But when we are looking only at the preclinical stage of the disease, only in subjects with asymptomatic Alzheimer's disease, and we want to differentiate people with amyloid to those without amyloid in the brain, it looks like that the structural MRI is doing a better job here with all these different estimated difference in the group as compared to the FDG PET. So this is a work in progress, and I hope that I will be able to tell you more about it soon. We have also used the MRI actually to quantify the functional brain change in Down syndrome. So this is a work that we have under review in Alzheimer's and dementia, where we use the arterial spin labeling technique to measure the brain perfusion in the brain. So you have here the haploid cognitively unimpaired individual, the group, the asymptomatic Down syndrome, the symptomatic Down syndrome. And in this study, we were able to also include a group with symptomatic Alzheimer's disease, a group of sporadic Alzheimer's disease. What we observe regarding the perfusion is that at the group level, we were not able to see a significant effect at the asymptomatic stage, especially compared to the haploid cognitively unimpaired. But we could see a decrease of the perfusion in the symptomatic group and also in the sporadic group. And what was very interesting is to look at this pattern voxel-wise, where we could observe that at the asymptomatic stage, we can already see reduced perfusion in the parietal lobe, in the posterior cingulate here, and also the posterior temporal occipital region here. At the symptomatic stage, this pattern of hypoperfusion is much more extended, and remind you the one that we have seen with the hypometabolism. And we can see a very similar pattern, although more significant, in the sporadic Alzheimer's disease. We actually compared the group with symptomatic Down syndrome to the group of sporadic Alzheimer's disease, and we were not able to see a lot of brain difference. This is this figure. There was no much result significant. However, if you just look at the effect size and account for the fact that we have little subject, we have some results that indicate that the pattern of hypoperfusion in sporadic Alzheimer's disease might be slightly more temporal lobe, slightly more pronounced in the temporal region, while in the Down syndrome population, it may be more inside of the medial, parietal, and frontal region. But overall, these are results like that are, I think, already quite promising as regard to the use of ASL in the Down syndrome population to quantify the functional change. Finally, I will enter in the last part of my talk where I will discuss about the vascular lesion in Down syndrome. So something that is very interesting also with the Down syndrome population is that they have a unique profile of comorbidities and vascular risk factors. So on one side, they have a higher prevalence of some risk that you will find in the general population, higher prevalence of some risk like the obesity, the sedentary lifestyle, or the sleep apnea. But on the other side, they present a lower prevalence than in the general population of hypertension. They also show less often type 2 diabetes, smoking habit, or metabolic syndrome. And actually, post-mortem studies have demonstrated that arteriosclerosis and arteriolosclerosis are very rare in Down syndrome and much less prevalent than in the general population. So these are like the typical small vessel disease that you can observe with aging. And together, this is indicating that is a profile of comorbidity that contrasts a lot with the one that you will typically find in the general population with aging, where both hypertension and arteriolosclerosis are highly prevalent. So in this sense, there can be a very interesting model also to look at the relationship between vascular pathology and Alzheimer's disease. And this was actually the objective of my Miguel Servet research grant, where the objective was to study different vascular pathology in the context of Down syndrome and sporadic Alzheimer's disease, to try to understand when this lesion, vascular lesion, emerged in the context of the disease, whether they emerge before or after Alzheimer's disease pathology, what is the relationship with the different biomarkers, and also how they can influence the cognitive deficit. So I will show you some results about this. I will start with results regarding white matter hyperintensity and microbleeds. So these are two typical neuroimaging features associated with cerebrovascular pathology. In this case, we observe that the white matter hyperintensity increase these are the association with age, and we observe that in the Down syndrome, the white matter hyperintensity increase much more and more strongly associated with age than in the general population, indicated with the yellow dot. Actually, when the two curves are separated, it is at the age of 44 years, which is not a common age to start to develop white matter hyperintensity in the general population. And this corresponds at 10 years before the first symptoms in the Down syndrome population. If we look at the presence of microbleeds, which demonstrate that there has been some microhemorrhage, we observe also a very strong increase with the age of this type of lesion. We can see that although there is only between around 10 to 20% of microbleeds until the age of 40, and this number increased up to 60% at the age of 60. We also look at the association with the clinical diagnosis, and we observe a very clear gradient for both types of lesion with the disease stage. The dementia group presents significantly more lesion than the prodromal group and the asymptomatic group. Regarding the asymptomatic group, we did not systematically find difference as compared to the euploid population, which is ear and ear. But you can see that there is a group of individuals that start to already show higher lesion, even though at the group level, this was not significant. We also assessed the association with the biomarker of Alzheimer's disease. I'm showing here the illustration for the association with white matter hyperintensity. You have this association with CSF A beta 4240, PTO 181, NFL, GFAP, and YKL, that are two biomarkers of neuroinflammation. And what you can observe across all these graphs are very strong association between white matter hyperintensity and all these different biomarkers. It was quite interesting that when we put all these different biomarkers in a same model, we only see that the NFL, only the NFL remain significantly associated with the white matter hyperintensity. And this kind of makes sense to us because the NFL is a marker of neurodegeneration, especially of axonal damage, so in the white matter, and it makes a lot of sense that it is associated with the white matter hyperintensity. We also look at the topography of this lesion. Here is the frequency map of the white matter hyperintensity across all individuals with Down syndrome. And we can observe a pattern that is mainly located in the posterior region, a pattern that is very periventricular and involved mostly the occipito-parietal structure. Actually, when we look at the change over time of the lesion, we see that at first the lesions are very much around the third periventricle, very periventricular, and they progress with time and with disease stage across the different into the juxtacortical structure, especially in the parietal and the occipital region. If we move to the microbleeds, here again we observe that the microbleeds are very lobar and predominate in the posterior brain structure, the occipito-parieto-temporal, posterior temporal and region, and also the cerebellum. You can appreciate on this figure all this profile contrast with the one that you will see in the euploid controls. First, there is more lesion, and they tend also to be more in the posterior structure. And if we look at the different clinical stage, at the asymptomatic, prodromal, and dementia stage, we retrieve at each stage this kind of pattern with the more involvement of the posterior structure. This is actually quite in line with what we have observed in a different study with cortical microinfarct, where they also predominate in posterior and parietal region. So what are telling us all these results as regard to the etiology of this lesion? So one pathology that likely explains part of this lesion is the CA, the cerebral amyloid angiopathy. So this is a pathology that consists in amyloid deposition in the vessel, and it tends to be more severe and more prevalent in the Down syndrome population because of the overproduction of amyloid beta than in the sporadic Alzheimer's disease and then in the controls. And the postmortem study that look at the prevalence with age were able to demonstrate that starting from age 43, there is more and more severe and moderate CA, which is consistent with the age where we are seeing the increase in white matter hyperintensity. It is also interesting to note that the CA is mostly predominating in posterior structure, which correspond with the topography of the lesion that we observe. It is also possible that there is other etiology that underlie this lesion that we observe. For instance, the white matter hyperintensity will result from a Wallerian degeneration that will be secondary to the neurofibrillary tangles. It is possible that they are induced by a subtle hypoperfusion, also that they reflect some neuroinflammation that can be related to the trisomy 21, to Alzheimer's disease, or also to the vascular pathology. Actually, we have some some results that kind of support the neuroinflammation pathway. We are having an ongoing study. The paper is almost ready that assess the longitudinal white matter hyperintensity in the Down syndrome population, so the evolution of this lesion over time. And what we observe, unlike our expectation, is that the white matter hyperintensity tend to decrease, or at least decrease, in a large number of individuals over time. So you have here the evolution of white matter hyperintensity with age, and here is once we analyze the white matter hyperintensity. And if we focus here, we can see that there is a large proportion of people at the symptomatic stage, and also the other individuals that present decreased white matter hyperintensity over time. So this was kind of an unexpected finding, because we thought that it will increase with the disease stage. So we tried to run different analyses to ensure that it was not a statistical, a methodological artifact. So we controlled, for instance, for the size of the white matter, but the result remained quite the same. We also asked to a neuroradiologist to quantify the white matter hyperintensity visually, being blind of whether it is the first or the second, the first or the last scan. And the results were also very similar. Like, there is a large proportion of individuals that do not show significant change over time, but there is a larger proportion of subjects that show a regression over time as compared to those that show progression. So this result indicate to us, at least is the way we are understanding them at the moment, that the white matter hyperintensity might be a bit unstable over time, and this could suggest that the neuroinflammatory process. Finally, we are also looking at other small vessel disease biomarker. I won't enter much into the detail, but we look at the perivascular space. We also look at some index derived from the TTI, which is the peak width of skeletonized mean diffusivity. It is a quite promising metrics piece because it has been shown to be a very sensitive biomarker of small vessel disease. And when we apply it to the Down syndrome population, our first result are suggesting that it can present an earlier degree of abnormality as compared to the white matter hyperintensity. And with this, I will move to my takeaway message. So the Down syndrome population is one of the largest populations with a genetically determined form of Alzheimer's disease. Depending on whether you count the APOE4/4 as a genetic, as an autosomal dominant Alzheimer's disease, it is or not the largest population. So it is very critical to study more the disease in this vulnerable population. And we also defend that beyond the high relevance and high importance to study for the population itself with Down syndrome, it can also provide new insight into the disease pathogenesis that can help us to better understand the sporadic form. In my presentation, I have shown you that the brain degeneration starts many years before the symptom onset. We have shown the specific vulnerability of the medial temporal lobe structure, and also the early dysfunction of the parietal region, which is a pattern very similar to the one that you found in sporadic Alzheimer's disease in the general population. And finally, we also assessed cerebrovascular lesion and found that they were associated with Alzheimer's disease symptoms and Alzheimer's disease biomarker. These are changes that occur many years before symptom onset, when AD pathology is already present. And we believe that the etiology is probably multiple, but it involved the overproduction of amyloid beta, for instance, with CEA and Alzheimer's disease, but probably also neuroinflammation and possibly other one. And with this, I would like to thank all my team, all the San Pamo memory unit, and especially the Down Alzheimer unit that is doing an incredible job in putting all this data together, especially Juan Fortea and Maria Carmona that are coordinating it. I would like also to highlight the work of the great team I have and all the students that I presented the work, including Sarah Giadani, Alejandra Morcillo Nieto, Maria Franquesa, Jose Ariola, and Benjamin Bejanin. And I want also to thank the patient that allow us to do this study. Thank you for your attention.
All right, thank you very much, Alex, for this very exciting presentation. So the paper is now open for discussion. As I said earlier, if anyone is interested in posing a questions to Alex, please do so by using the raise hand feature on the upper part of your screen. And if you have no microphone available, you can also do the questions in writing through the chat. Okay, so while we wait for the first question, let me remind everyone that CBNet webinar series are held every other week on Thursdays at 3:30 p.m. And if you're interested in actively participating in this webinar series, please send us an email either to Teresa Iglesias, who is the coordinator of the training program, or to myself, Miguel Medina, and I will do our best to accommodate a proper slot for your presentation. All right, so questions then. Don't see any raised hand yet. Check the chat just in case.
With the wave of it, maybe
Yeah,
it's taking outdoor energy for question.
all right, so okay. I believe there is no questions. I don't see any raised hands. Oh, questions coming through the chat either. All right, so let's try to break the ice and make a question myself, if you don't mind, Alex. This is a very generic questions and has to do with the heterogeneity of the clinical presentation for the Down syndrome. How do you take that into account when you do your analysis? Because there is quite a lot of heterogeneity in, let's say, penetrance in the symptoms in this population. So how you handle this issue?
Thank you, Miguel. Very good question, actually. So a disclosure, I'm not a clinician, so I'm not saying directly to the patient, but I do have some element to answer you. First, regarding the symptoms of the age at symptom onset, I mentioned this at the beginning of my presentation, and as surprising as it can be, there's the Down syndrome population is as homogeneous as the autosomal form of Alzheimer's disease, like the duplication of the APP gene or the presenil1. The age of symptom onset, if you look the dispersion of the age of symptoms onset in Down syndrome as compared to the other form of genetically determined AD, there is actually a lot of similarity. Regarding the heterogeneity of the clinical presentation, we consider that the main presentation is amnestic type, but we think that is also maybe understudied. And actually, recently, we published the case of a patient with posterior cortical atrophy, which is the visual variant of Alzheimer's disease. And this was one of the first cases with autosomal Alzheimer's disease, with Down syndrome, to present with an atypical presentation. And we think that there is probably other cases with atypical presentation that may be under diagnosis, because we focus most of our evaluation on the memory aspect. So I'm truly convinced that neuroimaging can actually be a way to to explore this heterogeneity because we are not like limited by the evaluation of the patient, which sometimes is complicated in patients with Down syndrome. And we can have directly access to the structure of their brain, the structure of the topography of the atrophy. And this can tell us if patients are more prone to have a posterior variant, a logopenic variant type, or the different variant. So these are actually studies that we are planning to do in a very short term in the team.
All right, very good. Thank you. All right, so any other questions? As I said, if anyone is interested in posting a question, please just use the raise hand feature on the top side of your screen, and I'll give you the floor to make the question yourself. Alternatively, you can also do question in writing through the chat, in case you don't have a microphone available. All right, seems like people are being very shy today. Okay, so let me also ask you another question, which is more out of curiosity. I'm not a clinician either, so but I guess that in this particular population, it must be a little bit challenging, especially you that you have a background in neuropsychology, to develop a specific assessments for this population, and assume that the regular ones that you use with elderly people, Alzheimer's patients, and so on, may not work very well in this population. So are there specific tools that have been developed and that you use for testing not only memory but some other cognitive functions in this population?
Yeah, so I'm not controlling fully this topic, but there are like a lot of different tests that have been developed specifically to screen dementia in patients with intellectual disability. One of the main ones we use is the CAMCOG, which explores different cognitive domains and is adapted to the intellectual disability of the patient. We are now having work in a multi-centric study on a second version, on an updated version of this test to improve still its screening capacity. And there is also in the memory unit, in the Down unit, we have also developed a version of memory test that is adapted, and other neuropsychological tests that are adapted to the Down syndrome population. But it's definitely a field where it remains a lot of things to be done, because for many years, Alzheimer's disease was totally understudied in this population. And so although we are pushing for this, and a few groups in the US too, there's still a lot to be developed, and for certain cognitive domain, is sure that there is new tests that will need to be created.
Okay, great, thank you. So are you aware of any of the Alzheimer's treatment being tested in clinical trials for Down syndrome patients?
Yeah, actually, the memory unit is involved in several clinical trials. There is a lot of debate inside of the Down syndrome experts in the research field and the clinical the people that visit patients to know whether we should offer to the patient the new treatment like the lecanemab. One reason in favor is obviously that they are all going to systematically develop Alzheimer's disease, so it's an excellent reason to provide them the treatment, since they are virtually determined to develop the disease. But on the other side, they also have a greater prevalence of CAA, cerebral amyloid angiopathy, and this is the main cause of ARIA, of secondary effect of this treatment. So it's very important that we start to test this treatment and do trials in this population. And I think we are still trying to figure out in the field whether the patient should directly benefit from it, or should directly benefit from it, or whether we should wait from data from new trials. So it's a very hot topic in the community.
Yeah, sure. I can imagine. Yeah. All right, thank you very much. Again, any other question from the audience? No questions?
You can let it here.
Yeah. Okay, so I guess if there are no more questions, then I think it's time to close the session here. But now, before thanking Alex for his willingness to share with us his work, and thank you everyone for attending. So I hope you have a great day, and then you have also air conditioning on because it's getting really hot everywhere. Anyway, so Alex, thank you very much, and thank you very much everyone for attending.